Everyone, thanks for joining us for this Institute webinar this morning. We are doing a webinar this morning on measuring and improving the patient experience of care, talking about surveys, tools, and approaches. Before we get started with our presenters, there's just sort of the usual housekeeping stuff. So there are a great number of you on the line today. So you are all on a global mute through GoToWebinar. But we do want to hear your questions for our presenters. So if you have questions during the presentation, feel free to type them into the GoToWebinar control panel. We'll be able to organize the questions and then get kicked off with them when we get to the Q&A portion at the end of the presentation. You don't have to wait to submit your questions. Feel free to send them as they come to you during the presentation today. And the one question I can anticipate from everyone is whether the slides will be available for this presentation, and they will. They'll be posted to the Institute website, as will a recording of the webinar presentation, and you'll get an email notification from GoToWebinar when that happens, so look out for that. Before I turn things over to Summer and Aaron, I'll tell you a little bit about the Institute. It was launched late last year as a public-private partnership between the Oregon Health Authority, the Northwest Health Foundation, and Quality Corps to offer a broad array of technical assistance to practices that are working towards the primary care home model of care. We've been working with technical assistance providers paired with 25 practices throughout the state and learning collaboratives that are wrapping up this month. We've also built a website where we post resources, including the recording of previous webinars that we've done and registration for future webinars. And we'll be releasing some online learning modules later this year or early next year. The Institute works closely with the Oregon Health Authority PCPCH program. You can read more about the program at their website, primarycarehome.oregon.gov. They just released information on the 2014 PCPCH standards and the accompanying technical specifications, which is a wonderful document with a lot of written information on the details of the standards, so you should visit their website to access those. I'm going to go ahead and hand things over to our presenters today. We're excited to have Summer and Aaron on the line to talk to us about measuring patient experience of care. Summer is a program manager for the Oregon Healthcare Quality Corporation. Quality Corps has been working to help clinics understand the importance and relevance of patient experience surveying to improve their clinical practice. Quality Corps organized a pilot of 24 clinics to field the CG CAPS PCMH last fall, including Multnomah County. Aaron worked with Quality Corps to implement the pilot at Multnomah County and is going to share their experience with us today. So I'll go ahead and turn things over to Summer to get us started.
Great, thanks, Erin. Good morning, everyone. Just to tell you what it is Aaron and I are going to share. So the objectives, we're going to describe the difference between patient experience and patient satisfaction, review survey instruments and fielding methodologies, discuss how to begin working within your organization to improve patient experience, and then it's great to have Erin with us to share her experiences from Multnomah County Health Department and their primary care clinic. I know there are a number of myths out there about patient experience. The ones on the screen right now are 4 persistent myths. During this presentation, I will share some information that hopefully addresses each of these myths. So the agenda for my part of the presentation is to I'm going to focus on explaining how to measure patient experience. I'll touch briefly on public reporting and provide some strategies and resources for improving patient experience. And as I said, Aaron will share specifics about the strategies Multnomah County has used. Many patient surveys are based on respondent satisfaction ratings of their providers and other aspects of care. Surveys that use rating scales, for example, from excellent to poor, tend to reflect respondent expectations and do not suggest what can be done to improve the ratings. In contrast, surveys designed to measure the patient experience go beyond simple ratings of care to focus on the critical and supportive interactions patients would ideally experience during their healthcare encounters. Such surveys ask patients to report whether or not they had positive experiences in areas that research has shown are important to patients, including ease of scheduling appointments, availability of information, communication with doctors, responsiveness of clinic staff, and coordination with other care providers. Because they ask patients whether or not certain events or behaviors important to them actually occurred or how often they occurred, patient experience surveys also can be useful in highlighting actionable areas that providers can focus on for improvement. Patient experience data are concrete and actionable in contrast to global satisfaction scores. So why is it important to measure patient experience of care? Ever since the Institute of Medicine's 2001 Crossing the Quality Chasm report codified patient-centeredness as one of 6 healthcare quality aims, patient-centered care has gained footing within the landscape of healthcare reform. More and more, measuring patient experience is becoming an explicit component of certification and compensation, a trend likely to continue in the coming years. Improving patient experience has an inherent value to patients and families and is therefore an important outcome in its own right, but good patient experience also is associated with important clinical outcomes. For example, at the practice and individual provider levels, patient experience positively correlates to processes of care for both prevention and disease management. For example, diabetic patients demonstrate greater self-management skills and quality of life when they report positive interactions with their providers. And patient experiences with care correlate with adherence to medical advice and treatment plans. This is especially true among patients with chronic conditions, where a strong commitment from patients to work with their providers is essential for achieving positive results. Measures of patient experience also can reveal important system problems, such as delays in returning test results and gaps in communication that may have broad quality, safety, and efficiency implications. Patient experience is also correlated with key financial indicators, making it good for business as well as for patients. For example, good patient experience is associated with lower medical malpractice risk. A 2009 study found that for each drop in patient-reported scores along a 5-step scale of very good to very poor, the likelihood of a provider being named in a malpractice suit increased by 21.7%. Efforts to improve patient experience also result in greater employee satisfaction and reduced turnover. And patients keep or change providers based upon experience. We all know this about our own care, and relationship quality is a major predictor of patient loyalty. One study found patients reporting the poorest quality relationships with their physicians were 3 times more likely to voluntarily leave the physician's practice than patients with the highest quality relationships. So there are a variety of ways to measure patient experience. Most of those listed here, as well as others, are useful. Well, all those listed here, as well as others, are useful in different ways. You'll note the second bullet, user-posted reviews, are probably not so useful to clinics, but they're definitely useful to consumers. And they send a clear message that consumers are looking for information about people's experience with the clinic, and an opportunity for clinics to satisfy that desire for information by considering, it is an opportunity for clinics to satisfy that desire for information by considering public reporting of patient experience data. And I'll talk a little bit more about that later on. I'm going to focus on explaining the CGCAP standardized patient survey as a tool to pinpoint opportunities for improvement. Once you've pinpointed those opportunities, you need to know how scores may be changing over time, how they compare to those of other organizations, and which issues are most relevant to your members or patients. Then it's the perfect time to employ some of the other strategies on this slide, such as focus groups and interviews, walkthroughs, shadowing, and mystery shopping, and I'll talk a little bit more about that later on as well. So about CGCAP. CAP stands for Consumer Assessment of Healthcare Providers and Systems. It's a free technical assistance and user-supported service through the CAPS user network. It provides the ability to compare to national benchmarks. It's endorsed by the National Quality Forum, and it's required for accreditation, certification, and payment by a growing number of national and state-level organizations. The HCAPS, or Hospital CAPS survey, is required by CMS for public reporting and for value-based purchasing, and CMS is also producing a physicians compare website that will likely include patient experience surveys as well. The CAPS Clinician and Group Survey is part of the NCQA PCMH Practice Recognition Program. CGCAPS is also included as a required quality measure in the proposed rules for accountable care organizations. And the doctor communication measures in CGCAPS are required by the American Board of Specialties for maintenance of certification. There's some core CAPS design principles. The survey content was shaped by input from patients and key stakeholders, including healthcare providers, plans, and purchasers. The surveys have a strong track record since 1995 of rigorous scientific development and testing to ensure validity and reliability. They assess patient and consumer reports about their experience, not just satisfaction, as I stated previously. Standardized instruments, data collection, analysis reporting, and benchmarking are all available. Supplemental items allow customization of the surveys to meet diverse needs, and all CAPS surveys are in the public domain and available free of charge. I'm going to focus on the clinician and CAPS, clinician and group surveys, the CGCAPS. There are multiple versions to meet user needs. There's a 12-month version, the visit version, and the patient-centered medical home version, which is actually the 12-month version with the addition of supplemental questions addressed at the patient-centered medical home. There are adult and child versions, and all versions measure the same core concepts. So just a quick overview of the survey, the core survey composites within the CGCAPS. They all include questions addressing access, or getting appointments and healthcare when needed, a global rating of the provider on a scale of 0 to 10, how well providers communicate, and courteous and helpful office staff questions. And the CGCAPS PCMH survey domains add composites around comprehensiveness, self-management support, shared decision-making, coordination of care, information about care and appointments, and access to care. So here is a quick overview of the 12-month visit and PCMH survey versions. You can see that all three versions of the survey use a 12-month look-back period for questions about access, and then the provider communication and office staff questions. The look-back period varies from 12 months with PCMH and 12 months, and the last visit with the visit survey. And you can see that there are additional domains around would you recommend the provider, attention to mental health, self-management support, and shared decision-making that can be added to any of the surveys. And as I'll show, actually, I know there's one of the myths is that the 12-month survey isn't very useful for internal quality improvement, but actually many organizations have found that there are a variety of ways they can use the 12-month survey results for quality improvement internally. I wanted to touch a little on the psychometric differences between the 12-month survey and the visit survey. The visit uses a 3-point scale, yes, definitely, yes, somewhat, and no, for the visit-specific questions about provider communication and office staff. The 12-month survey uses what we call a frequency 4-point scale for all questions, never, sometimes, usually, or always. And there's a little difference between the two scales. What we find is there is a significant, what we'll call the feeling effect. It is much easier to answer yes, definitely on the 3-point scale than always on the 4-point scale. And so that can skew your results. And we see this on this slide this is data from the 2013 from the clinician and group CAPS database. The CAPS database includes national benchmarks for all of the versions of the CAPS survey. And what you're looking at is the most recent data from the visit survey. You can see in the red box that for the items using the 3-point scale, yes, no, the 3-point yes, no scale, the scores for provider communication go from 85% in the 10th percentile to 96% in the 95th percentile. So there's not a whole lot of spread between the 10th and 95th percentile. Similarly, for the office staff, questions, there's not a lot of variation because it's easy to answer, yes, definitely. So we don't see a lot of variation in those top box scores. So there are a number of forces driving the PCMH survey, and many of these come from those psychometric differences and the implications of that. We're seeing a lot of national and state reporting initiatives converging around the use of the 12-month version. Here in Oregon, the patient-centered primary care home recognition program does not require the use of a CGCAP survey or patient experience survey, but points towards recognition are given, and that's in Standard 1A and Standard 6C. The Comprehensive Primary Care Initiative that is working with 70 participating Oregon clinics will be fielding the PCMH survey as part of that initiative. As I said earlier, NCQA provides additional practice recognition within their PCMH recognition for clinics that use CGCAPs for patient experience reporting. Accountable care organizations, the final rules require CGCAPs. They're in 7 domains, and 5 of the 7 ACO domains are in the PCMH survey. And there's growing patient expectation. So clearly this indicates that we need greater alignment of survey requirements. I've talked to many clinics across Oregon that are trying to figure out, where is the puck going so that they can skate to the puck and be ahead of the curve. And it is a challenging environment at this time, that there's not a clear direction of which survey instrument practices should be using, and the folks here at Quality Core, as well as at the national level and at the CAPS program, are recognize that, and we're all working for greater alignment of surveys to reduce the burden on respondents, to reduce the burden on practices, and to improve comparability of survey results for reporting and improvement. And we also recognize that a big barrier for clinics is the cost. And once you figured out what survey you think you should be using, how are you going to pay for a survey vendor, and that there needs to be continued research and testing to develop lower cost methods of data collection. From the clinician's perspective, as with any dimension of quality, measurement of patient experience provides a basis of information required for any effort to improve the system. Improving patient experience not only addresses those aspects of care that often matter most to patients, such as timely access to care, good communication, respect, and courtesy, but also has the potential to affect a practice on a more comprehensive level. From a clinical perspective, studies have shown that good patient experience is associated with patients being more engaged in their care and willing to follow their provider's instructions, as well as with improved patient outcomes. And as I shared earlier, that good patient experience also has been associated with positive business outcomes, such as lower malpractice risk, greater patient loyalty, strengthens ability to recruit and retain excellent staff, and improves clinician and staff satisfaction, and reduces the cost of rework. That if patients are experiencing better care and more engaged in their care, there's going to be less need for rework and the cost associated with that. So I said I would touch briefly on public reporting. I know that here in Oregon, everyone has gotten hopefully more used to the idea of publicly reporting on quality measures, as Quality Core has been doing for a number of years now. There is not standardized public reporting on patient experience, but that doesn't stop patients from wanting and seeking out that kind of information. Patients care about the interpersonal aspects of healthcare. Without access to systematic data, patients are turning to online review sites such as Yelp and Angie's List that do not provide representative data about a provider's panel. And this is a practice in the Bay Area, but with some comments just from last month, and not particularly favorable. So there are better ways to do this and to provide patients the information that they want in a more productive and useful way. Quality Core facilitated a one-time group purchasing pilot fielding of the PCMH survey last fall with 24 participating clinics, and 10 of those pioneering clinics volunteered to have their scores publicly reported. We are exploring opportunities, and this is how it looks on our website right now. We did not publicly report clinics side by side with each other in a comparative fashion. The public reporting right now, since it's only limited to 10 clinics, you can just look at each clinic independently. We are exploring opportunities to facilitate ongoing group purchasing and anticipate fielding the PCMH survey again in late spring. This opportunity will be open to all clinics. As with any group purchasing opportunity, the more clinics that participate, the lower the cost for everyone. Please email me or get in contact if you are interested, and we can keep you posted as more information becomes available and plans develop. And we're also working to align with practices that are already surveying their patients. So to leverage the surveying that's already happening and hopefully align around the PCMH survey here in Oregon. This slide and the next provide some ideas for how to use findings from patient experience surveys to improve patient experience of care. Data shows substantial variability and room for improvement. Research has demonstrated that the vast majority of the variability in patients' experience is due to the influence of individual clinicians and practice sites. The practice site accounts for at least 60% of explainable variation in patient-reported quality, and as much as 81% of the variance in organizational features of care, such as appointment access and clinical team integration. The individual provider accounts for as much as 84% of interaction quality, especially around communication and trust, and large-scale implementation bears this out. Massachusetts, for example, found differences as great as 36 percentage points in CGCAP scores between the highest and lowest performing practices. So once you've surveyed and have data in hand, there are a number of ways you can use that data. This slide and the next list some options, but there are even more options available, and there's some resources in the coming slide that you can look at and find some opportunities and strategies that will work best for your clinic. But you could use patient experience of care and data comments to create thoughtful reward and recognition programs. You could provide regular educational programs and webinars on these topics for your staff. Include a review of patient experience of care data and comments in all senior leadership meetings. Create formal patient-family advisory councils and patient-family faculty programs for all major services and practices. You could implement employee surveys to identify barriers to culture change and quality of work life for all staff. Chances are that if you have low patient experience scores, there are parallel low issues within quality of work life for staff and clinicians as well. You could expand service excellence training programs for all frontline staff. Implement some HR policies to link hiring, orientation, training, staff education, and performance evaluations to quality and safety goals, or implement leadership interviews of patients who have experienced a medical error and or who have had an experience of care on a quarterly basis, and share that across the staff. Patient experience surveying is best when it's part of a comprehensive strategy for listening to and engaging patients and families. Using CAHPS allows for benchmarking. Once you can pinpoint opportunities for improvement, you can use supplemental patient feedback strategies to dig deeper, such as conducting a walkthrough. During a walkthrough, one staff member plays the role of the patient, or you could engage patient partners in this activity. and another staff member accompanies him or her as a family member. They go through a clinic, service, or procedure exactly as patients and families do. They do everything patients and families are asked to do, and they abide by the same rules. They do this openly, not as a mystery patient, and throughout the process ask staff members a series of questions to encourage reflection on the processes or the systems of care and to identify improvement opportunities. The staff conducting the walkthrough take notes to document what they see and how they feel during the process. Then they share these notes with the leadership of the organization and quality improvement teams to help develop improvement plans. For many who do this, it is the first time they've entered their clinics, procedure rooms, or labs as the patients and families do. Clinicians are routinely surprised about how easy it is to, for example, hear staff comments about patients from public areas and waiting rooms. Walkthroughs usually turn up many problems with flow, signage, and wasteful procedures and policies that can be fixed almost immediately. And you could do this as a secret shopper as well and engage patients in that process. Patients and families care greatly about the experiences in your clinic and are key partners to identify opportunities for improvement and strategies to improve. Some ways to engage patients are to establish an advisory council or engage patients as partners on a QI team. The PCPCI website has resources to help you do this. There are a number of clinics doing this in Oregon and throughout the country, and I'm happy to connect any clinics that are interested with other clinics and resources to learn from. Oh, and the resources are at the end. Okay, I'm sorry. The resource slide is at the end of the presentation. So now I'm going to turn it over to Erin to share her experience at Multnomah County participating in both the pilot fielding that Quality Corps organized of the PCMH survey last fall, as well as the internal surveys and other processes that Multnomah County has used to measure and improve patient experience of care.
Great, thank you, Summer. And so yeah, I wanted to share our experience during the CAPS pilot, but also talk about our approach to serving patient experience in general, and then talk about plans for the future and some exciting things that we're testing right now. So why do we measure patient experience of care? This is exactly what Summer was talking about before. We are primarily interested in measuring patient experience of care because patients with better care experiences have better health outcomes. And I'll just wait a second for the slide to pop up here. But this information really does help us identify ways to improve our practice, which leads to better care, which also leads to healthier and happier clients. And it's really a key indicator in our industry. Like Summer was talking about, it's included in medical home recognition at both the state and the national level. And it's also a cornerstone of recent state and national legislation as far as the Affordable Care Act and CCOs. Sorry, it looks like the slide isn't advancing. So I'll just start.
Again, try just clicking on it, and we can take.
There we go. Ta-da! All right, thank you. So since 2009, we've been distributing patient surveys, paper surveys, to both our primary care, our school-based, and our dental clinics. And these questions are based on the CAPS survey. They're not the CAPS survey as a whole, but there's many similar questions. So we have 25 items with, questions on access to appointments and wait times, questions about patient-centered and team-based care, some questions about patient demographics and health status, and then also we have 2 open-ended questions. What do we do really well, and what can we improve? And the managers really like those open-ended questions, and staff do too, because you end up getting a lot of really rich information from that. And we do these surveys quarterly. And then what happens after those surveys are distributed is when they're sent back, we create these reports. This is just an example from October 2012, and it's a combination of bar charts and percentages. And so the clinic leadership takes these results, they share it and discuss it with staff and team meetings, and then they use these results to target clinic-based improvement projects. So one example of how patient satisfaction surveys led to some improvements was at our Mid-County clinic. There was a lot of congestion at the front desk, and that really came through in the patient surveys. They're saying it was confusing, it was hard to know where to go or what to do, and there was a lot of commotion. So one of our QA specialists worked with the team based on the patient feedback, and this is a diagram of kind of how some of the improvements looked. So they created better signage. They wanted to make clearer line markings, so where to stand in line. They moved the play area. It was right by the front entry, which, you know, having a play area right where people walking in was you know, led to a lot of the commotion. They set up a place to meet interpreters, and so on and so forth. And so this was all based on client feedback, and it ended up leading to a lot of really good changes. And this is just a picture of one of the line markings to show patients which way the line went. So why we participated in the CAPS pilot, we were really interested in aligning with community standards. We had our in-house surveys had many of the same questions that were on CAPS, but we had never used the entire survey. And we really recognized the value of all using the same instrument. So you can compare, you can benchmark, and we are really interested in being part of that learning collaborative, the pilot group, and figuring out, you know, what the best ways to do things as part of that collaborative. And we had questions about, you know, what would the return rate be? What were language needs? How many patients call our clinics directly with what kind of questions? Things like that. So we were really eager to test it. And so it was really valuable to do this. We could see how we ranked both internally and compared to the other pilot clinics. And it really ended up being a pretty seamless experience for our clinics. You know, it was externally mailed to our patients as opposed to our current survey process where we're, you know, handing them out in the clinic. So this happened a little more behind the scenes. There weren't really any questions. Patients didn't seem to be confused about why they were getting surveys in the mail or whatnot. So that was really seamless. Things to look into, the survey was available in English and Spanish, but we have, our clientele has a lot of different language needs, and so that would be something in the future that we would want to address more fully. And then just other methods of delivery, you know, mail might not be the best way. So we'd be interested in finding out, are there ways to do CAPS in person? And in the next slide, I'll talk a little bit more about that. And just a note, we tested the CAPS survey in our primary care clinics, but not in our school-based. So next steps, what we'd like to do is we plan to issue CAPS once a year and then issue our internal survey more frequently. And ideally, we'd like to have kind of continuous real-time feedback with our internal survey. And so what we're doing right now is experimenting with an iPad pilot, and we're right in the middle of that. We hired a couple of interns to go to our clinics with an iPad in hand and ask patients about their experience directly. And so that's it's going really well, and we're learning a lot from that. And possibly even in the future, we're looking at getting maybe a kiosk to do a similar type of thing. So it's not as much a quarterly, you know, paper-based manual process, but something that's always going on. And you know, we have the ability to get that real-time data. And then, like someone was talking about earlier, we're also looking to supplementing our surveying process with more qualitative measurements, so shadowing, walkthroughs, you know, day in the life experience-based design. They have a lot of names, but basically just looking at really understanding what our patients' experience is, from the moment they come in or the moment they call to the moment they leave. I think we'll be able to get a lot of really rich information from that as well. So that is what we're doing currently, and then our plans for the future. And I'll turn it back over to you, Summer.
Hey, it's Kate. So we're looking for questions now. We've had a couple come in, but please don't be shy about using the GoToWebinar questions control panel to type your questions and submit them to us. I'll go ahead and get started with some other questions that we got during the presentation. So the first one was, is there a specific time frame or date that people will have access to updated national benchmarks, or what sort of national benchmarks are currently available? And I thought Summer could address that.
Yeah, so the CAPS database does keep national benchmarks. However, if anyone's tried to look at either the CAPS database or the the CAPS website that is part of AHRQ and the Department of Health and Human Services, you'll note that there are issues with the website. There have been some contract lapse, and negotiations are underway, and so things have been slowed down. I don't have an exact time frame for you right now, but if you are having any issues getting the benchmarks that you're looking for, please feel free to email me. I have some contacts within the CAPS program and can try to get any answers to your questions there.
Okay, there was also a question about why is CAPS, do you think, sort of the survey of choice, or why has it been recognized by all these different entities as sort of the survey of choice?
Well, I think that everybody wants something that's standardized across the country, that allows for national and local benchmarking and being able to compare apples to apples. And that came for hospitals with the HCAHPS, and then with CMS saying that it was going to be a requirement for for payment, really established HCAHPS as something that all hospitals needed to do. There was an expectation that would happen with the CGCAHPS, and that CMS would declare that it was required. That requirement hasn't been as fast coming as many of us thought, but I think that it is out there and being required in a number of different ways, and that's growing. I know that it's that there are some complaints about the CAPS survey, and I think that it's hard for one survey to be everything to everybody, but the survey is rigorously tested, and questions developed with patients and practices to try to meet everybody's needs.
So there was another question that sort of, I think, tacks on that one, which is ultimately, are you endorsing the CAPS survey? And I think what I'm hearing you say is that it's out there. A lot of organizations are looking to this survey as sort of a good standardized tool and aligning requirements around it. And would that be a fair answer to that question?
Yeah, yes, I think it would. And I guess I don't want to necessarily promote one survey over another, but I think it's important to, surveying is an important part of a comprehensive strategy to improve patient experience, and to use a survey that has national benchmarks seems to make sense. But then, in addition to that, especially if you're only using the survey, you're fielding the survey once a year, that you have to have more real-time information about how patients are interacting with your clinic, and especially being able to test any changes that you're making based on the opportunities that the CAPS survey or any other survey identify. And so that, another part of that comprehensive strategy is to identify supplemental patient feedback opportunities, and then to engage patients and families in doing that.
So there was a question for Erin that someone actually shared, a webinar attendee shared what they did. So the question for Erin was about what you learned from the survey experiences. So what sort of feedback did you get that you were able to sort of put into action? And one person, before we have Erin speak to that, said they were able to change their phone tree. They heard from patients that they found it difficult and there was too many options, and so it was too hard for patients to navigate. So getting that feedback allowed the clinic to make changes to their phone tree to make it easier for patients to get calls where they needed to be. So Erin, what kind of stuff along those really specific lines did you learn when you participated in the fielding of the survey?
Well, I think, the interesting part was that a lot of what came through in the CAPS pilot was what we've been seeing in our internal survey. The questions were based on CAPS, so that's good. That's a sign that our measurements are aligned, so that's good. But one of the things that really came through was the fact that the measurement was spending enough time, and so we've been working on that measure across the board. And I think one of the most valuable things for us in testing, being part of the CAPS pilot, was just seeing it was an entirely different way of the method of serving. So the content was very similar to what we've been seeing all along, and so we were kind of used to taking that feedback and incorporating it and making changes based on that. But for us, the test of the pilot was less about the content and more about the method of surveying, so through the mail, with an external vendor, just seeing kind of how that would work. So, and we learned it was pretty seamless, but I think it's like I was describing, we really want to have that be a piece of our patient experience surveying and really do a lot of real time and then some qualitative measures as well.
Great, thanks, Erin. So there are some questions about related to how the survey is administered. So there are folks sharing that they give surveys to patients while they're in the waiting room because they see that means that the results are real time and they don't need to wait for them. So as people are considering whether they should field the surveys through the mail or through other ways, what are some of the considerations around that, and why is this different than handing surveys out on the waiting room?
That's a great question. So especially when you're, if you think about the cost of of using a vendor to administer the survey. So when a third party administers the survey, they're pulling a random sample of your patients, so there's no bias. If you're handing surveys out in the clinic, a survey might not be handed to someone who just came out of an appointment and is clearly unhappy. It's hard to control for that kind of bias. So if you're using a vendor, it eliminates that bias. Of course, it does introduce, if you're sending it only by mail, introduce the bias of who opens their mail and who doesn't. But the vendor can also oversample for specific demographics to try to make sure that they're getting survey response from a broad spectrum of patients that are representative of a clinic's group of patients. There also is actually, I think that we often think that it's going to be more expensive to go with a vendor because you have to pay the vendor, obviously, and there's a set budget for that. But there is a cost that is incurred if you're doing it in-house, even if you're handing it out in the clinic. The time it takes to put together the surveys and to explain the survey process to patients and to train staff to hand it out, that actually with good group, especially with group purchasing, I think, and good negotiation, you can get hire a vendor to do the survey for you and have it really not cost any more than what it would cost to do it in-house. We just don't always capture that in-house cost because it's staff that you're already paying for. So, I think that, and we can definitely, debate what's the best survey administration methodology. Should it be mail? Should it be phone? Should it be email? Should it be a mix of those? I think it seems like the national research is moving towards a mixed survey administration methodology. So doing mail and email with phone follow-up. But again, that administering a survey is, in this, fashion using a vendor is only, one piece of the comprehensive strategy for improving patient experience. And there's definitely a place and a value to doing in-clinic surveys and other supplemental, patient feedback practices, comment cards, focus groups, shadowing providers and patients, engaging patients and families, but that it's important to get that those unbiased responses that you can get with a third-party administration of a survey.
Excellent. So someone else asked, is it recommended to change questions on the surveys routinely, quarterly, yearly, using the same types of questions, or should you use the same survey sort of indefinitely?
Well, I think that it's important to use the same survey, year over year to be able to compare your own scores and benchmark over time. Again, that doesn't mean that you can't do additional surveys or change questions for other fieldings of a survey throughout the year. But it is useful to use the same survey. If you're going to use the PCMH, the CG-CAPS PCMH survey, for example, to use that same survey annually over time to be able to benchmark your own scores. And you can add questions to the survey in addition to the supplemental questions that CAPS offers. You can add as many questions as you want for your own fielding. But I would recommend using at least once a year using the same survey to allow you to have answers and responses to the same questions over time.
Excellent. So this sort of speaks to that. I mean, you've mentioned this next question. You've mentioned there's ways you can do supplemental things in between. So maybe if you want to vary up the questions or vary things up, you could do it then. But someone asked about how it can be actionable or how you can use the information if you're only doing it one time each year.
Mm-hmm. Well, I think that even if if you're fielding the PCMH survey, for example, once a year, that it can really help identify and pinpoint opportunities for improvement, and that you can take action right away, on those opportunities. You can identify, for example, that patients aren't having the kind of interaction with office staff, for example, that the clinic would like them to have, and it's pinpointed that opportunity, and then the clinic can decide what makes most sense in terms of strategies for improvement. I think that if you're implementing strategies for improvement, you probably want to test those more frequently than just you don't want to wait a whole year to test them again, and see if your strategies have yielded improvement. And so I think that's when it's really important to look at some of the supplemental patient feedback strategies. And can I move forward to the resources page? Yeah. Okay. So the CAPS improvement guide listed here on the resource page is quite a long document. The analysis section, which is about a third of the way into it, provides a number of different strategies and goes into a lot more detail of, about how to do a walkthrough or shadowing or those opportunities. So it's a great resource that way.
And so these are not hyperlinks. You can't, if you click them, if you're trying to click them right now, you won't be able to click them. It's not just that it's too early in the morning and you haven't had enough coffee. It won't work. But it is linked from the Institute website. The page that this webinar is on, the improvement guide, is linked from there. It's posted to the Institute website as a resource. And then in the PDF document, set of the slides that we saved after this presentation, you'll be able to get the hyperlink from there. So those of you trying to, get right on it and click on it, it isn't actually, you can't get it yet.
And I shared some of the slides from the myth busting using the PG-CAPS 12-month survey for quality improvement webinar. But that is a complete 1-hour webinar with slides and audio is available, and we'll have that linked from the PCPCI website. And there's some great experiences from Massachusetts and from a Wisconsin clinic talking about how specifically they've used the PG-CAPS 12-month survey for quality improvement. So I would highly recommend checking out that webinar.
And then, so there are a couple of comments and questions related to survey links. So the question that, that I think we've heard from people is, what can you say about people thinking that the PCMH in particular is too long? And there was someone who wrote in and shared that, they have decided to focus questions on certain areas that they're trying to work on and improve. Because they may perceive how they're doing, but they may be surprised by what patients hear. They thought too many questions were a problem, and that when they were giving patients the 8-page survey, they weren't getting as many back. So they reduced it to 15 questions front and back in one page, and they get more completed and turned in. So I'm just wondering if you can talk a little bit about the length and how people have, what there is to say about that challenge and how,
Yeah. So it is a long survey. It has, as I said earlier, it has been rigorously tested by the folks at CAPS, and patients do complete it and don't really have a problem with the length. That said, I can completely understand why a clinic would want to narrow their focus for regular surveying, more frequent surveying to a smaller set of questions. I think that it's important, and we didn't spend a lot of time talking about this, but to not lose sight of the public reporting aspect, that patients really want this information about their own clinics, but they also, they want to be able to, if they're picking a new clinic or just trying to see how, how they feel about their existing clinic, that they're looking for this kind of information, this experiential information on the internet now. And in the absence of standardized, well-vetted survey results, that they're creating their own, whether it's Yelp or Angie's List or other websites. I mean, we know anecdotally that, and from research, that the most common source that people look to when looking for a new doctor is their friends and family, and so looking for experiential, and anecdotal feedback from others on the internet is sort of just an extension of that. And so I think the more that we can move towards providing standardized results that are based on valid and useful surveys for both clinics and patients, the more we can, provide that resource to patients and get away from, the Yelp and the Angie's List that are, a great place for patients to vet about a bad experience or champion a provider and a good experience, but not necessarily what we want patients to be going to as a resource for making decisions about, where they should get their care. So it's important to use for quality improvement internally, but we don't want to lose sight of the role that it plays in and the importance of that information to patients.
Excellent. So we have just a couple of minutes left and a couple more questions. If there are any last-minute questions, please get them in now. So since you mentioned the public reporting and that was part of what Quality Core did in the CAHPS pilot. Are the analysis procedures that Quality Core used for the CAHPS pilot published somewhere to help understand how the results were generated and put together?
I think they're on our. They should be. They're on our website, and I can confirm that the methodology that was used for the existing public reporting on the quality, the patient Partner for Patients website is based on the top box methodology. So it's the number or percentage of patients that respond with the highest category for any given question. That's the pretty standard methodology and promoted and recommended by the CAHPS survey.
And then there was a question about trying to find an example of the survey or a copy of it on the AHRQ site. Someone was having trouble, so we'll maybe be able to post some links or something to help people do that. And they were just had some questions about if it's cross-culturally, educationally appropriate, reading level, grade level, the different languages available. Can it work for dual diagnosis site clients, caregivers serving as a proxy? So, the user asks questions. Are there ways that vendors sort of flag that to tally it? So can you speak to some of that? And maybe we can also follow up with this particular person offline with some links to information.
Yeah, so the survey questions have been tested across different cultures and for different literacy levels, and they I think CAHPS continues to do testing to ensure that the survey is relevant and useful across populations. What was the other?
And just sort of maybe we can point to some resources or information because I'm sure they publish information about how all that was done. So we can follow up with some links and post those too about what they have done so this particular person can identify any gaps. So if there are any questions, please go ahead and type them into the GoToWebinar control panel. And if not, it's just about 9 o'clock and we should be able to wrap up. I think the last thing is, again, we will post the slides, a recording of this presentation, the improvement guide, the link to the longer webinar about busting the CGCAHPS myths that Summer referred to after the webinar today. So those will be available on the Institute website, which is www.pcpci.org. You'll also get an email from GoToWebinar later today with a link that will take you right to the page where all this stuff is so that you don't even have to remember to go there. GoToWebinar will send you a reminder in your inbox. The last thing is there is some contact information here for both Summer and Erin, who, if something they said in the webinar today presented a particular question for you or you have some individual circumstances they can speak to, please feel free to reach out that way. And then the last thing is when the webinar ends today, a survey will pop up on your screen. We'd really love it if you could take that survey. It helps us develop even more excellent webinar presentations in the future. We really appreciate the feedback from webinar attendees. And thanks a lot to both Erin and Summer for sharing what they know about surveying for regarding patient experience with us today. We really appreciated their insights, and we hope everyone has a good rest of their day.